It's nice to meet everyone. My name is Vladimir Chukанov. I'm currently on my 6th year of studying in Dnipropetrovsk State Medical Academy. And right now I'm going to show you my presentation. So my presentation is about influence of HIV, hepatitis, co-infection, and survival and life quality among patients with HIV. Let's start. So the aim of the study is to study the influence of HIV plus HCV or HPV co-infection on survival rates and quality of life of patients against the background of performing antiretroviral therapy, or ART, as I'm gonna say it later on. The research tasks are: first is to study prevalence of markers of HCV and HPV in a cohort of HIV positive patients. Second, to study influence of viral hepatitis B and C on survival rates of people infected with HIV. And third is to estimate the quality of life of patients with HIV plus HPV HCV infection using the health-related questionnaire that I'm going to show you later. Object of the study is HIV plus HPV HCV co-infection, and subject of the study is quality of life and survival rates of patients with HIV plus HPV HCV co-infection. The methods that we were using was socio-demographic and epidemiological analysis of patients admitted to the AIDS center in Dnipropetrovsk state with confirmed HIV diagnosis, clinical and biochemical analysis of prevalence of serological markers and verification of hepatic damage in a cohort of patients with confirmed HIV. Quality of life of patients with HIV plus HCV or HPV diagnosis was evaluated with health-related quality of life protocol. It's a questionnaire that have 36 questions, and according to that, it gives you like a picture of how mentally and physically healthy the person is. The higher the value, the better. Statistical processing of the obtained data was carried out with the use of the software of Statistica 6.1. Study design and study groups. So first we did a retrospective study in a cohort of 501 patients with confirmed HIV, divided into 3 groups according to the stage: the mild stage, moderate stage, and severe stage, the stage of HIV, of course. And afterwards, from that group, we made an analysis, and we found people that have HIV plus HPV, HCV co-infection, and we divided them into groups. The first group that received ART for at least 2 years, and it was 27 people, and the second group that did not receive the ART, it was 41 people. The inclusion criteria was confirmed HIV plus HPV HCV co-infection, and exclusion criteria was HIV plus hepatitis of other etiology. So the results, as you can see from this graphic, we have 501 people with confirmed HIV, and 2% of them was mild severity, 14% of them was moderate severity, and 84% of them had severe cause. The next graph shows us the amount of people and division by age and sex. So the most vulnerable group was people from 30 to 39. And as you can see, there is more males than females in common. Here we can see the distribution of patients who have HIV according to the stage by the World Health Organization. First stage is 2%, second stage is 10%, third stage is 33%, and fourth stage is 55%. The next we see is the biochemical markers of blood of the patients of the first group and the patients of the second group. The first group, the one that received the ART. And from the provided data, we can see that there is decrease of liver function, especially of protein metabolism, pigment metabolism, and coagulopathy. The changes were registered in both groups, and but these changes were more prominent in the second group, the one that did not receive the ART. The distribution of chronic hepatitis among patients. So in the first group, HCV was presented in 36.8% of patients, and HBV was only 3% of the patients. The second group had 41.2% of HCV patients and almost 20% of HBV patients. As you can see, the HCV is more frequent. And by the way, in the second group, the HBV is more frequent than in the first group. Here we can see the risk of the development of unfavorable course of co-infection of HIV and HCV. According to the data, we can see that in a year of observation, the risk of these adverse events is 5%, while in 60 months of observation, it was nearly 10%. That's for the HCV. And for the HBV, we can see that in a year of observation, it was 12%, while in 60 months, it was nearly 40%. Here we can see the cause of death among the patients who have HIV. So the most common cause of death for HIV patients is the tuberculosis, and HIV plus hepatitis co-infection is only 3% of this. So here we can see distribution of patients group according to the age and control. Here we are examining the quality of life of patients using the HRQOL protocol. As you can see, in comparison of the results, it showed us no difference in the quality of life between group of patients with HCV and a patient co-infected with HIV plus HCV. Well, it may differ, but just a little bit. While we also found that this protocol scales decreases dramatically in both groups with chronic hepatitis C, regardless of the HIV status, with the progression of liver fibrosis. So in conclusion, first, chronic viral hepatitis B and C possess an important place among other co-infections in HIV-positive people. HCV is about 32% and HBV is 9%. In the observed cohort of the HIV-infected patients, HCV co-infection prevails, and administration of ART does not influence the frequency of serological markers of HCV. In comparison, the prevalence of chronic viral hepatitis B among patients who receive ART was lower than group who did not receive ART, which can demonstrate the efficiency of antiretroviral therapy both to control replication of HIV and HBV due to inclusion of tenofovir into the schemas. It is established that co-infection of HIV viral hepatitis increases the risk of unfavorable course of HIV infection during long-term ART. Chronic viral hepatitis B increases risk of poor outcome 4 times, whereas HCV increases only 2 times. Progressive liver disease significantly worsens the health-related quality of life in both groups of patients, HCV and HCV-HIV co-infection. Health-related quality of life in all domains is lower in HCV, HIV co-infected patients, especially the psychological component of health. Okay, thank you for your attention.
So, thank you very much. Any questions for our participant?
So, may I ask you, Volodymyr?
Yeah, of course.
You have said that 41 patients didn't receive antiretroviral therapy for at least 2 years. For what reasons?
That was because they were not doing it themselves. So
not due to adverse effects.
no.
Yes, thank you.
It was their decision, the patients. They were just not doing it.
I understand, thank you.
I have question. May?
Yes, of course.
In your presentation, there are many people with tuberculosis. Why?
There's not many people with tuberculosis. That's the World Health Organization statistic about the most common cause of death.
You not see such patient in your department.
We see them frequently because they sometimes arrive, but it's not the point of this science work. Yeah, the tuberculosis is just a big problem in Ukraine, so there is a lot of patients with co-infection.
Thank you. Now, in schemes of treatment COVID infection, present tocilizumab. What do you know about negative influences of these drugs on heparin? Thank you.
Covizumab, right?
Tocilizumab, yes, in scheme of the treatment COVID infection. What do you think about influence of this drug on the heparin?
Well, actually, I haven't heard.
Maybe acute episodes, yes, on insufficiency of heparin, yes, after.
I think that the epidemic is still going on, and it's pretty early to discuss all the negative episodes, and we need more time to understand.
Thank you.
The more long-term damage to the liver.
Thank you.
Thank you.
So, any more questions to our participant? If no, we can tell thank you.
Okay, yeah, thank you very much.
Yes.